Oh,
Um, I'll just say we're having a few technical issues for everyone. For the attendings, please hold off a few moments and our speaker will be here shortly. Thank you.
I wonder if Manish is having a hard time getting on too.
Did he text back, Ankush? There's actually a lot of participants right now. Just be patient, please. Having some technical issues.
hi guys.
How are you?
Chiba, how are you?
Good, good,
How's everything?
good. Refreshed and refreshed until I got logged in. So
Yeah, yeah, national outage.
exactly.
We're communicating with Dr. Aggie right now just to check, and we'll keep you updated in a few minutes, everyone. Okay, here you go. Thank you so much.
All right, sorry about that. It wasn't
No
working.
worries. We're actually live on the webinar. We
Hey,
didn't want to
Manish.
lose speakers. Thank you for joining. I know we had some difficulties. If you want to try putting your loading your slides.
Yeah, will do.
Awesome. Let me say a few words. Hey, Manish, Kostas here.
Hey,
Hey, on behalf of the Tumor section, we're excited to have you join our webinar series today. Just for the group, this is going to be recorded. I know there were some difficulties with Zoom this afternoon. but I'm sure you're going to enjoy Manish's talk. You'll get a more formal introduction, Manish, but I just want to say a few words. He is our former tumor section chair, so he's done a lot for tumor section through the years, and we've worked together on a number of things. So this is just another nice webinar in our series. I want to thank our early career neurosurgery subcommittee, and of course the AANS, who's done so much work on this with us to make these happen. Thank you.
Yeah, again, thank you everyone for being patient. I'll introduce Dr. Manish Aghi. He's a neurosurgeon scientist and a professor and vice chair of neurological surgery and faculty in the Graduate Division of Biomedical Sciences at UCSF. He's also the leader of the UCSF Neuro-oncology program as part of the UCSF Cancer Center. He's authored over 300 papers and 30 book chapters and several books on brain tumors, and he served on the editorial boards of JNO, Scientific Reports, Journal of Neurosurgery and Neurosurgery. His basic science lab has been NIH funded since he started the faculty, and he studies genetic changes in tumor cells and the cells in their microenvironment as they contribute to aggressive biology and therapeutic resistance in brain tumors. From 2018 to 2020, he was elected to and served as the chair of the American Association of Neurological Surgeons, CNS Joint Section, and his research and work has received numerous awards, and he's done great things for the tumor section. Really appreciate you being here, talking to all of us on this webinar.
Well, thank you, and apologies for the technical issues this morning, but I'm really honored to be invited and to see the growth in the educational programs that the tumor section's been offering since my time leading it, and kudos to Casas and the team for getting all this content out there for surgeons and other providers. So I'm going to be talking about the management of recurrent glioblastoma, and the way I have sort of structured this is, we're going to sort of assume that we are talking about patients who've received standard Stroop protocol following maximal safe surgical resection whenever possible, or a biopsy whenever that's not possible, and then concurrent temozolomide and radiation followed by temozolomide alone. And then, as we tell patients all the time when we first meet them, that standard protocol will provide a statistically proven benefit in progression-free survival and overall survival compared to the absence of those treatments. And that is why, not just in the US, but in the EU and elsewhere, that is what patients receive at diagnosis. But it's really at recurrence, which is inevitable, where a lot of branch points and challenging decision-making occurs. And we tell patients that we will be part of the team making their decision, helping them make decisions about how to manage recurrent GBM. But the decision-making certainly becomes complicated because there isn't sort of a standard algorithm per se for managing recurrent GBM. And so I've broken this up into surgery, which is where myself and several of the people on this call have the most expertise, as well as conventional DNA damaging chemotherapy and its role in managing recurrent disease, repeat radiation and its role, and then talk about where FDA approval fits in terms of recurrent GBM, and then as a surgeon scientist, I think it's always important to think of the biology of GBM recurrence and whether that gives us any insights into what we might be doing wrong or what we could be doing differently, and where the future may take us, which is, the biology is a logical leaping point for that. So starting with repeat surgery, I think what's interesting about this is when you look at most institutional series where they will disclose concurrent series of patients and what portion of them are actually offered reoperation at first recurrence, it does tend to run at about 1 in 4 or 1 in 3, and this is for a variety of reasons, but in general, patients who undergo re-resection are usually younger with better KPS and smaller tumor size, and really each of these is associated with better outcomes with repeat surgery, and so there's a self-selection, if you will, for getting the best candidates in for repeat surgery and being a little more stringent with our candidates for repeat surgery than we are for initial surgery. And that's because at initial surgery, while all of those things are important for outcomes, they become even more important for repeat surgery, because now you're talking about a scenario where surgery is losing some of its power compared to at initial diagnosis. And that's mainly due to the biology of the tumor, the fact that it's already seen chemo and radiation and may have a degree of multifocal spread beyond what even the MRI may show. The other thing to consider is how soon was the recurrence when we talk about second surgery. So in most of the series, the median time from first to second surgery is about a year. And in general, increased time to first progression is associated with better outcomes when we go to repeat surgery. And that makes sense. I mean, if you've got a tumor that biologically progresses or radiographically progresses within a few months of a good initial surgery, there's reason to believe that the biology of that tumor will not make it a great candidate for second surgery. That, if you did everything you could the first time, you may just be up against a difficult disease in that setting. And we've looked at this at UCSF. Many years ago, Nader Sinai, when he was a resident, looked at it. It's been revisited in follow-up studies as well. And when we, again, with the obvious caveat that these are all retrospective studies, if you look at that caveat and the fact that the patients undergoing repeat surgery will have good KPS, there is the same sort of benefit for gross total resection at recurrence as exists at the time of diagnosis. And in fact, gross total resection at second surgery can even overcome some of the negative effects of subtotal resection at first surgery. And so when we look at repeat surgery candidates in our tumor board and as neurosurgeons, we tend to focus even more than at the initial surgery at the potential to achieve a gross total resection. And this can be augmented, and this can be the probability that can be augmented with intraoperative MRI or 5-ALA or all the adjuncts that many of those on the call, such as Custis and others, have tremendous expertise with. But it really should be the goal with repeat surgery whenever possible. In the interest of time, I could talk for 30 minutes about repeat surgery, but I want to touch on so many different modalities. And so while we're on the subject of surgery, I did want to spend a little bit of time talking about LIT. And the reason for some of the appeal of LIT is that it is a less invasive alternative to repeat resection for recurrent GBM. And so as a result, when you're dealing with patients that are, maybe with a slightly less KPS and less good candidates for resective surgery, LIT can have some appeal there. And so LIT is, as many of us know, is really using thermal injury to create 3 zones centered around the tip of the laser. There's the zone where you'll get a good necrotic core with maximal thermal injury, and followed by a zone of sublethal cell damage, followed by a zone of physiologic hyperthermia. And although that necrotic core is really where you get the maximal killing, it's outside of that zone. You will still get some benefits, including pro-inflammatory pathways that could interact with immunotherapies, which are of tremendous interest in GBM and recurrent GBM treatment. It's an effective alternative, as I said, particularly for unresectable deep tumors. And the LIT complication profile is generally related to tumor volume in terms of thermal injury and necrosis, and can be reduced considerably by limiting the procedure to tumors up to 15 cubic centimeters in volume. And there's a number of good series for LIT in the setting of recurrent GBM. The group at WashU St. Louis has extensive experience with this and talking to them. And when they published their initial series, which at the time was one of the largest series for LIT and GBM in general, they had 58 treatments, and the majority of which, 41, were in the setting of recurrence. And what was interesting about this series was that they found that the benefits were even greater in terms of PFS and overall survival when they use lit in the setting of recurrence, more so than even in the setting of newly diagnosed. And this becomes a little tricky to tease out, but it may be due to the fact that in the newly diagnosed setting, these were essentially patients who were undergoing biopsy rather than resection. And so technically, if you wanted to compare it to, and this is not a comparative study, and the historical Stu protocol may not be the ideal comparison, because a newly diagnosed patient with a deep-seated tumor may have a particularly limited prognosis that is hard to capture in sort of historical controls. And so there may be some interest in randomized studies, but regardless, in the setting of recurrence, these results were certainly intriguing and certainly puts lit as an option for recurrent deep-seated GBMs that are not amenable to surgical resection. So I wanted to, having spent the beginning of this talk talking about surgery as a surgeon, sort of shift gears and borrow from our neuro-oncology colleagues by talking about cytotoxic chemotherapy for recurrent GBM. And when we are at our tumor boards and recurrent cases are presented for surgery, we as surgeons will always say, yes, we can take that out, but what else can you do? Because, I think we know by now that if you just re-resect a GBM, a recurrent GBM, and don't have something good to offer afterwards, you'll probably be right back where you started within a few months. And so what are the options in terms of conventional DNA damaging chemotherapy for recurrent GBM? And interestingly, I would say I would call this slide, it starts where it all began. In, temozolomide, there was an initial tendency to say, well, if it recurred, why would you give it temozolomide again? And the reality is, you actually can consider temozolomide for recurrent GBM. And there's two scenarios where this can be done. The first, which is sort of, logical and common sense, would be if the patient made it through 6 months of temozolomide and then stopped, as is often the case, and were just being observed and then recurred or relapsed after a interval where they were off TMZ, then it would be very reasonable to put them back on temozolomide, even if you didn't reoperate. The other thing, which is sort of been explored in a variety of studies, is even if they progressed on TMZ, sometimes shaking it up in terms of your TMZ protocol can lead to a period of response in a tumor that was otherwise refractory to temozolomide. So the standard regimen, as many of us know, is 150 to 200 mg per meter squared for 5 days in every 28-day cycle. But this can be shifted in the setting of progression to continuous daily low dose, like a metronomic TMZ, which is in some ways felt to be more anti-angiogenic than cytotoxic. So cutting the dose by about 3 to 4-fold, or shifting your on-off cycles to be a little more aggressive with giving it to 75% of the days over a 1-month period, so 3 weeks on, 1 week off, or at a 50-50, 1 week on, 1 week off cycle. So you're really shifting from the initial, which is really just 5 out of every 28 days, to increasing the frequency and hitting it a little bit harder. Maybe you're capturing more cells when they're cell cycling than you would in the other standard protocol. Obviously, any discussion about TMZ, whether it's in the setting of newly diagnosed or recurrent GBM, needs to acknowledge MGMT promoter methylation status. And in the setting of recurrence, we need any conversation about MGMT methylation status should look at the status at the time of the recurrence. And this is, potentially the value of getting tissue through a resection before you consider putting someone back on temozolomide. And promoter methylation status will change in about 1/3 of recurrent cases, more often from methylation to unmethylation, not surprisingly, and just in terms of the biology of the tumor becoming more aggressive. But what is interesting is that the promoter methylation status at recurrence doesn't seem to correlate with the benefit derived from some of the alternative TMZ regimens given at recurrence, which may be, as I was alluding to earlier, that you're targeting the stroma with some of these regimens, such as an anti-angiogenic effect, rather than being directly dependent on targeting the tumor cells themselves. And so these are some of the considerations that go into TMZ, but I did think that any conversation around cytotoxic chemotherapy at the time of recurrence has to start with TMZ. But there are certainly times when, it's clearly a progression on TMZ, and you want to think about alternative DNA damaging chemotherapy, whether it be by itself or after re-resection. And this starts really with lomustine. Lomustine is the most common cytotoxic agent used for recurrent GBM. It's given once every 6 weeks, 1 week out of 6, at about 80 to 110 mg per meter squared. And it's considered such a standard of care option for recurrent GBM that it's essentially the choice for the control arm in numerous landmark recurrent GBM studies listed here, both in the US and in the EU. And particularly in patients with MGMT promoter methylation, it's very common for lomustine to be considered the standard of care at the setting of recurrence, even though it's not the standard of care when it comes to sort of the way TMZ is at upfront, where you say, oh, 75, 90, or even 100% of patients get it at the time of recurrence. But it is the standard of care when you design a randomized trial and you say, what do we compare it to? So it's sort of a different definition than the definition at diagnosis. But in terms of response, it's not great. It's not as good as TMZ in the setting of a new diagnosis. The objective response rate is really just around 10%, and the progression-free response rate is really barely 2 months, and a 6-month PFS is about 20%, and the median overall survival is 7 to 9 months. Nonetheless, it's never really been beaten by any other systemic agents in the randomized studies that have used it as standard of care. So it sort of remains the default boxer that we're putting up against recurrent GBM, even though recurrent GBM keeps knocking it out pretty quickly. Nothing else seems to do better. And so, we have to do better, but this is an option, and there are a subset of patients that can respond somewhat favorably, or at least favorably enough to combine with re-resection and provide some benefit. And so that is what I wanted to say about cytotoxic chemotherapy for recurrent GBM. And that brings me to re-irradiation for recurrent GBM. And initially, this was really thought to not be an option. We tell patients sort of that radiation is a one and done thing. And for most of them, it is. And that is because 90 to 95% of the recurrences will occur within the high dose radiation field. And that really lends credibility to the initial studies that said that the majority of GBM recurrences occur within 2 centimeters, which is what led to those fields being defined. But it also underscores that, that the initial radiation, fractionated radiation therapy we provide is obviously not, is not durable in the sense that patients recur in field pretty commonly. And so when they recur in field, it raises concerns about toxicity when we re-irradiate. But with sufficient passage of time and smaller recurrences, there may be a lower risk for radiation necrosis with re-irradiation. And so we think about this as an option for patients who are not surgical candidates, who have good KPS, and where more than 6 months has passed from the initial radiation. And this has been looked at in broadly speaking, both the context of single treatment SRS for small recurrences, as well as fractionated or hypofractionated radiation therapy for larger recurrences. And so in SRS, really 5 well-powered studies have looked at delivering 12 to 18 gray for recurrent GBM with reported median progression-free survival of about 6 months and overall survival of 10 months. So a little better than what we see with things like lomustine. And radiation necrosis, even when you select for patients with smaller tumors, is still going to be seen in about a quarter of the cases when you're using SRS. Fractionated radiation therapy, whether it's conventionally fractionated or in the setting of recurrence, more commonly hypofractionated, can lead to comparable results as SRS in terms of progression-free survival and overall survival, but with lower incidences of radiation necrosis. And so that makes it appealing. I think with GBM, we like to think about combinations. Obviously, the more you hit it with, the better. And so many people have advocated for combining re-irradiation with alkylating agents, and whether that's going to be better than using either one alone. There was a single-arm study a couple of years ago that combined hypofractionated radiation with low-dose TMZ for recurrence. They found that better KPS was associated with better outcome, but interestingly, MGMT status fell shy of statistical significance in terms of predicting progression-free or overall survival with a p-value of 0.08 in that study. And a really nice ongoing study in the European Union is the Legato study. Will be looking at radiation plus lomustine, again, hypofractionated radiation over 10 fractions, and lomustine at standard dosing compared to lomustine alone. And this will really give us some insights into this question of whether the combination at recurrence, just like we do at the time of diagnosis, is something we want to pursue more frequently. In my remaining time, I wanted to touch on FDA approval for recurrent GBM and use this for a springboard to talk about bevacizumab. So right now we have FDA-approved treatments for recurrent GBM. Two that I wanted to touch on. One was bevacizumab, and the other is tumor-treated fields. This is just the calendar of FDA-approved therapies for GBM. We're not talking today about carmustine wafers, but that's still out there as an option with FDA approval dating back to 1996. TMZ we talked about for newly diagnosed and maintenance. And then bevacizumab and tumor-treated fields are really what I wanted to touch on here, since they didn't fall under the umbrella of any of the other sort of DNA-damaging chemotherapy or radiation therapy that I had talked about earlier. And so bevacizumab is a VEGF-neutralizing antibody that is anti-angiogenic, devascularized tumors. It received accelerated FDA approval for recurrent GBM in May of 2009. And the approval was maintained in place despite randomized trials showing no benefit on survival in newly diagnosed or recurrent GBMs. And the reason for that is that it may still be effective in certain cases of recurrent GBM, and it is difficult to identify those patients ahead of time. And there does appear to be a benefit on progression-free survival in some series, even if there is no benefit on overall survival. The ongoing studies are in place to better understand when we should consider bevacizumab. Several studies have looked at bevacizumab combined with repeat radiation. And just like the use of hypofractionated radiation with alkylating agent chemotherapies, there does appear to be some benefit when it is used alongside hypofractionated radiation. So there is some consideration there, although those studies are considerably older. And there's a number of active trials looking at bevacizumab, particularly in the setting of recurrent GBM. And some themes that emerge are looking at imaging modalities to identify responders, such as PET, combining it with checkpoint inhibitors to take advantage of the effects of bevacizumab on the T cell population, and looking at intraarterial infusion of bevacizumab as well. And then the last sort of agent I wanted to touch on was tumor-treated fields, which are delivered via electrode arrays placed on the scalp. And they're designed, the intention originally was to disrupt tumor cell division by creating alternating electrical fields. This is low intensity, about 1 to 3 volts per centimeter, intermediate frequency alternating fields that exert biophysical force on molecules known as dipoles that are charged and polarizable. So these molecules, which are most commonly found in the microtubules that assemble during cell division, will be altered in the setting of these electrical fields. And TTFs have been shown to improve progression-free and overall survival. This is the landmark study from JAMA that showed it in a large cohort of patients. In this case, the population was slightly mixed for newly diagnosed and recurrent, but they were essentially early in their disease after initial chemoradiation, with the median time from diagnosis to being randomized to receive TTF plus TMZ versus TMZ alone being just 3.8 months, so sort of skewed in the direction of newly diagnosed. But a post hoc analysis of those patients who had TTF at true recurrence revealed that the median overall survival in patients who received TTF plus chemo after first recurrence was pushed from 9 months to 12 months compared to chemo alone. And since bevacizumab was one of the more common agents for chemo in that post hoc analysis, they broke it down for bevacizumab alone in this study that was published later in CNS Oncology, and found that there, even with bevacizumab, the TTFs plus bevacizumab alone, you get 9 months versus 12 months overall survival benefit. And so this was all of this led to FDA approval for TTF in the setting of recurrent GBM. Nonetheless, it is not used super commonly. This is a meta-analysis that overall showed the same sort of results when you pool a variety of studies in the setting of newly diagnosed versus recurrent GBM. But some of the things we see are that the benefits for overall survival are dependent on compliance, and there are issues with compliance around TTF. It is a little bit, seems to be asking a little more from patients than some of these other treatments. And the predominant adverse effects seen in more than a third of patients are dermatologic. So this is out there as an option for patients, particularly in the setting of recurrence, where we do, as this entire talk is illustrated, have limited treatment options. But it is obviously pushing the curves out a little further, but certainly not by any means curative. The biologic effects of TTFs go beyond the antimitotic effects that were originally speculated upon. These dipoles, these proteins and molecules that are affected by TTFs are involved in a variety of biologic effects in the tumor, including DNA repair, autophagy, anti-tumor immunity, invasion, and the permeability of cells to chemotherapy, all of which suggests a role for TTF combined with things like chemotherapy or even immunotherapy, not necessarily in isolation. So in my sort of limited remaining time, wanted to talk a little bit about the biology of GBM recurrence. And these are two studies from very recently within the last year, one from my institution and one from outside, that looked at, and I really think, one of the keys to unlocking our understanding of the biology of GBM recurrence is the more matched pairs we get from patients at diagnosis and then patient tissue analyzed at first recurrence, the more power we can get to understand the biology of recurrence. This first study did it transcriptomically, and the second study on the lower row did it proteomically. And at the transcriptomic level, you can see that individual GBM cells at recurrence, and when you look at single-cell RNA-seq, will shift from the pro-neural single-cell phenotype to the sort of mesenchymal, more aggressive biology at first recurrence. And this is driven by the AP1 transcription factor. This study also interrogated the immunologic profile of recurrent tumors and found that while most of them were T-cell depleted, just like at diagnosis, a subset of them had increased T-cells associated with a hypermutation phenotype, and that was a prognostic factor in the setting of recurrence. The proteomic study that I alluded to earlier had even more sample size, 123 matched pairs, and they found increased neuronal activity at the protein level in GBM tumor cells at recurrence, driven by Wnt and BRAF pathways. And this was actually reversible in preclinical models with BRAF targeting. These two studies, one might think are conflicting in the sense that the first study at a transcriptomic level looks at shifting away from pro-neural cells, And the second one looks at actual increased neuronal activity. But it's important to understand that the second one is at the protein level and the first one is at the transcript level, and those things don't always overlap. And the specific transcripts that define a cell as proneural in the first study are different than the proteins that define a cell as neuronal. So they may not even necessarily be conflicting, but may be interrogating different aspects of the biology. But I think the more we continue to ask these questions, the better equipped we will be to empower future clinical trials to address GBM treatment in the setting of recurrence. And so my last slide, I just wanted to say that, I think the future for this disease, I did not even touch on some of these treatment modalities because they remain more in the setting of clinical trials, but immunotherapy obviously remains at the forefront of what our scientists and our clinicians are trying to do to target GBM, both at diagnosis and at recurrence. Numerous studies from groups, including those at Duke and elsewhere, have looked at challenges related to the sequestration of T cells in GBM patients and the low mutational burden of GBM, which essentially makes it more of an immunologically cold tumor. And these limitations may make vaccination protocols that require antigens or the presence of T cells challenging, or even checkpoint inhibitors become challenging when you don't have T cells in the tumor. But experimental protocols such as CAR-T that bring the T cells to the tumor could be very appealing and have produced very encouraging results. Viral therapies, a significant component of these involves around enhancing an immune response and kicking up an anti-tumoral immune response. The key to these protocols, in my experience, has been getting viruses to spread in a manner that keeps up with tumor spread. And there's a lot of ongoing debates about whether this should be done with or without resection. The resection may create a sink, which the virus just pools in. And so that is a subject of debate, as well as the role for convection-enhanced delivery when you are injecting these agents into tumors. TERT promoter mutation is something of academic interest right now because of how prevalent it is in IDH wild-type tumors. Not yet druggable, but efforts are underway in groups such as Joe Costello's to be able to drug it. And then precision medicine really had some buzz many years ago. And while GBM has less mutations than most solid tumors, there are about 20 to 30 good genetic alterations per tumor, which offer the potential to customize treatment to individual tumors. No success yet to date. In fact, there's some evidence that GBM adapts quite quickly when you hit it with a molecularly targeted therapy. We've seen this with EGFR inhibitors in the clinic, but it is still possible that a pooled precision medicine protocol may unleash breakthroughs that we have yet to see to date. And so I apologize for the late start, but hopefully this has provided you with some cause for guarded optimism. We've seen that the prognosis for GBM patients has improved over the past decade, but the median survival does remain poor. And the setting of recurrence, the management is just far less standardized than it is at the setting of diagnosis. But I would encourage people to think about repeat surgery if a meaningful extent of resection can be achieved, or repeat radiation in select cases, as well as clinical trials. And one thing that could be an entire webinar on its own would be the importance of considering quality of life in all of these treatment decisions. Everything I've presented was about numbers, and numbers do not do justice to the impact of these treatments on the quality of life, particularly in the setting of recurrence. And so it's very important to have personalized discussions with your patients before embarking on any of these treatments, which can be quite a lot for a patient who's already been dealing with the diagnosis for a year or longer in these cases. So I thank you for your time and open it up to any questions.
Thank you. Thank you so much. That was very thorough and a great presentation. Any questions from the panelists, Shiva or Ashish?
Yeah, thanks, Yashua. Thanks, Dr. Agi. It's good to see you. Great presentation on a very difficult topic, difficult subject for our patients, recurrent glioblastoma. I had a question about the role of surgery, specifically in sampling the glioblastoma tissue, recurrent glioblastoma tissue, as you're going through a clinical trial, for instance, because you mentioned how the tumor changes from a proneural to a mesenchymal tumor, presumably from treatment-induced selection driving process. do you think we should be, as surgeons, participating in recurrent glioblastoma trials that are testing new therapies by sampling the tumor as we're going through that trial, either through a stereotactic biopsy or some other means, so we can understand more how the actual tumor evolves during those trials that invariably fails in a recurrent glioblastoma?
It's a great question, and there was a you know a consensus statement about that advocated for doing so. The one caveat that I would say is that sampling, particularly in the setting of recurrence, is very prone to spatial heterogeneity. And I was in a trial for replicating virus where we were the study was only injecting the virus into tumor with no resection, and we were required to just get tissue to confirm GBM before we injected. And there would be cases where we'd have to take like 12 samples just to get histologic GBM on a frozen section. Because these are patients who've been treated, so spatially there will be some necrosis at your needle tip. And so so I think that's one of the challenges with needle biopsies in the setting of recurrence. But if done correctly, it can have real value. It's just, the caution of doing it thoroughly.
Okay. Thank you.
I know you guys have published your experience with radiosurgery, and obviously the main concerns are radiation toxicity, which can be quite high. Although when you use it with bevacizumab, it can not only be synergistic, but it can be very safe. I know radiosurgery has been debated because of the results of the 9305 trial, and therefore is not typically offered, at least initially, for focal recurrences. Right? What do you have to say about that?
Sorry, you were cutting out. Offered for.
So what I'm saying is that radiosurgery, I know you guys have published your experience. The main concerns are the toxicity, which can be as high as 1/3 of the cases. But when used with bevacizumab, it's not only synergistic, but it can be very safe, with rates of necrosis being less than 5%. But it's not typically offered, at least initially, for patients, except if they are frail or there are no other options. But it's becoming more utilized. And if you look at the results from recent studies, and I think you show about 5 papers in one of your slides, 5 studies, the PFS and the OS and the post-progression survival is actually not worse than many trials, and not worse than chemotherapy, so even with resection. So that's just something that we've gotten more interested, and I don't know what your experience is. I know you guys.
It's a great question.
Years ago.
I would say we don't re-irradiate a lot, but we definitely do. Like, we see so many patients that it's not the majority, it's a minority that are getting re-irradiated. But the re-irradiation cohort, which is substantial enough to be able to look at experience, it tends to fall a little more on fractionated treatments rather than single treatment frame SRS. But even when we fractionate it, it tends to be 5 to 10 fractions. It's not a huge imposition on the patient, and we don't see a lot of necrosis. So it does seem like anecdotally we're selecting the right patients for it. We have some experience using Bev in cases where we might be concerned about necrosis. I feel like those cases we've only added the Bev when the imaging is raising some concerns early on about potential necrosis, and not necessarily used it from the get-go with the radiation. But I do find that over time we are starting to do more. We're also seeing, with a few more cases of recurrence out of field. In those cases, we're not even worried about the Bev, so we're just resecting and re-irradiating in 10 fractions, and they do great. But for the infield cases, we're doing a little bit of Bev, not a lot.
Thanks for the wonderful talk. We have one question from the audience here from a medical student. The student's asking, do you approach patient and families in counseling them differently for reoperations and recurrent GBM as compared to when you do an initial operation in terms of predicted postoperative course and quality of life?
So I walk them through, so there's sort of two categories of patients for reoperation. And if I did the first operation, then we have a bit more of a rapport, and they often will remember discussions of risk benefits at the time of the first surgery. And so what I typically tell them is that, you've now had a year of chemotherapy and radiation, so you're a little bit, diminished in terms of your immune system, even if your KPS is the same as what it was, which it often isn't. And so I say, because of that, we're adding 0.5% or 1% to your risk of things like infection or hemorrhage, and it's still a small risk, and we wouldn't be offering re-resection if the risk was substantially larger. But I sort of walk them through that. And then, we also talk a lot about length of stay and expectations. Things like rehab and skilled nursing facility, and because some of those, the discharge home rates drop a little bit with second surgery than first surgery, and I walk them through that, particularly if they were able to go straight home the first time, that maybe that's not as guaranteed the second time. And then there's a second cohort of patients where they had their initial surgery elsewhere. And then amongst those patients, there's a subset where the initial surgery was something emergent or urgent and just hard to fully get to the bottom of, but they describe being in the hospital for multiple weeks. And in those cases, you're obviously just sort of saying, look, something was different then, and that's not sort of typical for re-resection. And they're usually actually hearing something that was much better than they experienced the first time in those cases. And then there's a subset where they just had a routine surgery the first time, but it wasn't with me. And so then I give them a more detailed description. But short answer is that we describe it, and then we look at the scan compared to the first one side by side, and the anatomy and how things might be a little different. Certain things I spend more time on, like recurrence in the insula, I talk about in detail a lot more, because that I've seen sort of actual complications in the brain become a little more frequent in that scenario. And I sort of talk them through some of the decision making that goes on in those settings.
Thank you. I think that was great. This was recorded, will be available on YouTube. And thank you. Sorry for the technical issues as well. And hopefully we'll see each other at AANS, and we'll restart our webinars after AANS. Thank you, everyone.
Thank you so much.
Thank you. Take care.
Thank you so much.